Welcome everyone, and thank you for joining us today for this KT Canada seminar series. My name is Mo Donald. I am here in Calgary, Alberta, and I'm very fortunate to live, work, and play on the Treaty 7 region of Southern Alberta. And also, City of Calgary is also home of the Métis Nation of Alberta Region 3. And today we're very happy to have with us Dr. Tamara McCarron, and I'll introduce her quickly here. I'll give her a description, and three lovely panelists that are joining us in a fireside chat today to discuss an area dear to my heart in terms of patient partners and patient-oriented research and all the concepts around engagement. So I'm happy to be moderating this session. Before I introduce Dr. McCarron, I'm going to just go through a few logistic and virtual operational things. So basically, once the fireside chat is completed, there will be time for questions and comments, but feel free to add questions and comments through in the chat box, and myself and Megan will be monitoring that. And so also everyone has been muted on entry just to ensure that we can hear our presenters that are in our panel today. And basically, as I said, I'm happy to introduce Dr. McCarron, as she's a colleague and friend here that lives just outside Calgary. And she has a PhD and an MBA, and is a senior research associate with our group, which is the Nephrology Research Group, and is an adjunct assistant professor here at the Community of Health Sciences at the Cummings School of Medicine at the University of Calgary. And one thing I know about Tamara is that she is passionate about engaging patients and family members in health research. And I myself have had the privilege to learn from her and look forward to listening to hearing from Karen and Nancy and Heather today as our panelists. I'm going to hand it over to you there, Tamara.
Thanks so much, Mo. I was saying to Mo yesterday, it's so nice to have a friendly face around the table. I consider Mo not only a colleague, but a dear friend. So thank you so much for that lovely introduction, and welcome everybody. Appreciate the opportunity to have this exciting conversation. As Mo indicated, I'm very biased towards the involvement of patients and family members in research. And we'll talk a little bit more about that. But I thought this was a wonderful opportunity to have a conversation with individuals around, what are the challenges, and now that we've done all this great work in patient engagement, and there's lots of things that are happening, how can we sharpen that saw and really think about engaging beyond the usual suspects? So I am going to share my screen with all of you so that we can have this great presentation. So slideshow, play from the start there. Now everybody should be able to see this in full screen. If Mo is good, it's a thumbs up, it's good. You can see it, excellent. Okay, perfect. So as Mo mentioned, I have three panelists with me, and I wanted them to introduce themselves to you. So I'm going to start with Nancy, please. Could you introduce yourself to the group?
Certainly. Hi, good morning, and thank you for including me. I'm Nancy Verdin. I live in Red Deer, Alberta. I have been a patient and family advisor in research since 2018, and have had that opportunity to experience the journey and the development of patient inclusion. So thank you very much, and I'll pass it back to Tamara.
Okay, and Heather, welcome, Nancy.
My name is Heather. My pronouns are they, them. I am a PACER grad as of last year, which is wonderful. Through that, I've done a whole bunch of different kind of patient-engaged research projects. So like I've been doing a queer-based research project on queer health barriers. I've been acting as a patient advisor and activist since about 2019. Originally through the YAMPAC Council with EHS, but I've kind of expanded to a whole bunch of other ones. The big things that I think are really important is including as many different kinds of voices as possible, because whenever the voices are richer, the information is richer.
Absolutely, and welcome. And Karen, last but not least, of course.
Hi, my name is Karen Moffat, and thank you for being here, everyone. I'm from Cochrane, Alberta. I have been a patient partner for about 5 years. I too graduated with Heather from the PACER course last year, and I'm just starting to be involved in 5 different research projects that are just starting to get underway. So thanks again for including us in this conference.
That's great, and thank you. And I was just realizing I am unable to share my screen in full screen. Every time I stop, I lose everything. So Megan, remember that moment where we said that we might need to, if it's okay, I'll stop sharing as we get into these different perspectives, but I've lost all my presenter notes, and that's never a good sign.
Okay.
And so
Do you want me to share from my end?
If you could, I think that would be great.
Yeah, no problem.
Yeah, thank you so much. I know that's why we do this, but I just realized I lose that when I hit the full screen. It just negates that ability. I'm sure it's probably one of the settings, but we didn't get through that this morning. So just in the spirit of keeping the presentation rolling. So thank you so much. Thank you ladies for, I shouldn't say that. Thank you so much for that introduction, folks. I know we all look like we're ladies, but that may not be the case. And so thank you again for that great introduction. I'm just going to hit out of that for me. Perfect. And then thanks, Megan, as well, for taking over the presentation piece. So our learning objectives, I don't see the full screen now. That's okay.
Sorry, just give me a sec here.
Yeah, I don't know why it's not working for us this morning, but this was the problem I was having as well. So it's not a big deal. We don't have to be in full screen mode. This is not a text heavy presentation. This is really about the panel. So I'm actually okay going back to sharing screen. If we just want to do the small view, I'm okay with that too. But just the learning objectives, because these are those administrative pieces, but we're always asked to include some learning objectives. So we're hoping to have a thought-provoking conversation that really challenges our understanding of patient involvement and health research specifically, and to provide a seed for future conversations and discussions on how we continue to move this work forward in a meaningful and, as I like to call it, productive and mutually beneficial way for everybody. So not only the researchers and others that engage patients and family members in this way, but also for the patients and family members that put their hand up to do this great work. Next slide, please.
How is it
see the
now?
slides.
You don't see anything? Okay.
No.
Let me try one thing here. Let me try one thing.
And if all else fails, like I said, I'll take it over and I'll just leave it in small view, and that's fine with me. We structured the presentation really, as mentioned, like a fireside chat, and that's why we're all like blown up probably in your view, because I want to sort of give the feeling of sitting in a living room with these amazing individuals. We'll be asking 3 very general questions in 3 specific areas. We tried to be not vague, but big enough in the question asking that it would maybe be relevant to more people on the panel. And so we have time at the end of the presentation, as we mentioned, and we encourage the use of the chat option, and Mo is going to be helping with that, as was Megan, as already mentioned. And so we now should be on slide 5, which is,
Just give me a sec here.
it's okay. There we go. Perfect. That's where we are. So I wanted to set some of the context really quickly before we dive into our panel component. And so for those of you that work in this area, this is going to be familiar to you, but those of you who maybe do not, I thought I would sort of provide some additional thoughts and help with that context. So when I started my PhD, I think it was in 2014. It's funny how memory goes away. You don't even know when you start some of these milestone things. But when I started my PhD, the concept of patient as a partner in research was non-existent. I referenced 2 scoping, well, there's a scoping review that was part of my PhD that I had the privilege of actually working with patients. We called them co-investigators at the time. Again, this language didn't exist, but we're very curious about the investments that were being made from the systems perspective, whether it was the health system or other organizations that actually engage patients in health research. So we wanted to know how are we building the capacity of these individuals to even do some of this work? And so that's the first study that I mentioned. The second study I mentioned is a scoping review that we just recently completed, again, with patients. I had them involved in various stages and work throughout the scoping review to really understand the concept of patient as partner. But I just contrast the two studies because, again, the first study was 2019 published. The concept didn't exist. And then 2021, the second study, now we're talking about it in full force. So this space, I would really describe it as evolving. And it's changing on a regular basis. And the academic literature about how we're involving and the outcomes and all it's just fast and furiously changing. And it's exciting to see. And it's a great space to live and work in, really. But despite all of this, we still lack a clear definition. I would even argue with the people around the table from different parts of the province, you likely refer to your patients and your family members in different ways. So I wanted to ask, like, even in the chat, if you could put the patients that you're working with, how do you refer to them, or how do they refer to themselves? How do they define themselves? Even when we got going, I know the three panelists actually describe themselves in different ways. And so it is interesting, but just to, get people's juices flowing, things like patient advisor, patient partner, patient research partner, this concept of patient to be inclusive, to include family members. So we're not always saying patient and family members, so there is no clear definition. The other thing that's still a little bit on the fuzzy side is the guidance. Now, we all know about CIHR, and I call them the mothership. So CIHR really has invested in this area, and all of the work that I've talked about today has been advanced. I like to give the props to CIHR for really moving this work forward. But the reality is that even though those frameworks are in place, the how do we do this? Like, how do we bring people in? How do we support them? What kinds of things should they be doing? It's not there. Unfortunately, in some situations, what has ended up happening are things like a tokenistic kind of an experience that patients have had. When I say patients, I mean patients and family members, people going, why am I here? Like, this is just a checkbox. And this is exacerbated even further in some of these like unusual suspects, these marginalized groups. And the three panelists that we have today actually do represent some of those marginalized groups. And so we want to get into the meat of this presentation. And so the next slide, please. Sorry, I was going to advance it myself, Megan, and then I realized I can't. So we're going to start with the first question. And we were joking with Nancy this morning before everybody connected that Nancy missed our last, we've had several meetings in preparation for today, excuse me, and she missed the last meeting. And so when I did a follow-up email, I said, Nancy, you're the first person. And she said, I'm being punished because I did go to the last meeting. I'm being punished, I know. But Nancy really had the most perspective on this question. And so we, again, we're trying to understand we're starting to challenge our understanding of how to engage patients in health research. So Nancy, from the population from your lived experience in the population that you are speaking for, what do you think some of the barriers that still exist are? And I'll ask the second part after you've had to kind of answer the first. So what do you think some of the barriers are that still exist?
Well, first of all, thanks very much for this opportunity. That I actually have been, my first research project that I started on was 2018. It's still ongoing. And back then, quite honestly, I really believe that my primary investigator really didn't know what to do with me, that they wanted me as part of a presentation as one of the early grant. It was the Dragon's Den type style. And I did speak at the event. But after that, it was sort of like, well, you're here, how do we include you? What do we do with you? And they certainly were not the first ones. And we're still seeing that many, probably, I hate to use the word most, but I do think that's a possibility, that many researchers, their training doesn't include patient engagement. It doesn't often include qualitative. I'm also a PACER grad, passionate about qualitative work. And when I see that, and that's where a lot of the tokenism comes in. It's not that they don't want to use us, they really truly don't know how. So there's no education for them. They really don't even have anybody to talk to that says, so how did you use this? How did you work with this person? How did you include them? How do you make them a part of your study? When, as we've talked about with patient partners or patient research partners, whatever title we use, we also have a gradient of education and knowledge. And how do I include everybody at every level at a meaningful way for them? So we're asking a lot of our researchers, if you think about it, that the training is really about quantitative, which in comparison, and I speak as a non-researcher, seems easier in many ways than trying to include another unknown commodity, which is the patient. And so we certainly lack education in that one. We lack resources. Where do they find out about it? Who do they talk to? And unless they happen to have that connection, then they're searching. And that's one of the things that I think is key, is to build that resource. Other barriers include even personal people skills. Okay, there's lots of reasons why people go into research, and there's lots of levels of patient engagement by connection. So I've met researchers that are amazing, and they're passionate and they're excited and they want to know more about the patient, how we can do more. I've met other researchers that literally look at me and shake their head and go, well, you're here. You tell me what you do. So like I say, we've got that gradient that's really a huge problem. I think part of the lack of understanding is bringing in the balance the patient voice provides. And this even goes back to some of the other committees and such I'm involved in, that many of the doctors will say to me, you remind me why I do my job. You remind me why I'm here. And it sort of grounds what's going on. And when we look at research and we bring patients into it, there's that real mixed message. Well, I need your voice. I need you here in order to get my grant. I don't know where I'm going to put you or where. So it's the same thing repeatedly, right? I keep repeating myself. And along with that, I think is a need or a potential for building patient and family skills as well. They don't have to be researchers, but potentially a better understanding of the research format can help them fit in as well. Because I think as patients, it's not uncommon for the patient to have similar feelings that I don't know what to do. I don't know who to talk to. I don't know what to ask. And there's a couple of really good experiences that really emphasize why patient and family are so valuable in research. And many years ago, I was at a conference and the keynote speaker spoke on quality of life for patients on dialysis, and I happened to be one of them. And she went through her paper, explained all the different surveys they used and all the different methods that they used. And in the end, she said, well, with all that data, we found out that our intervention made no difference at all. The numbers are all the same. And I'm sitting at this conference trying not to explode, that I didn't feel it was appropriate to respond to that at the time, because you don't want to embarrass your keynote speaker. The key was, and this also speaks from my own experience, had they included the patient voice, they would have found out that indeed the numbers are the same. The person is different. So very often this goes to a course I talk on living with chronic illness. I'm a retired occupational therapist. And we did a pre and post survey with our groups every time. And 98% of the time they would say to me, well, my pain is still the same. And I'm still struggling. I now have hope. I'm not by myself. I know there's new ways to manage my energy. I now know that I have more control than I thought I did. This was an excellent course. Thank you so much for having me. So those are the things that are missed when we focus on quantitative only. The other thing we bring as patient advisors is a bigger depth and context to the data. And I think that gets missed as well, because, and this came out of a recent project I'm working on, where we had done, actually it's been an amazing one, in fact, that all the people that are on the patient and family advisory committee have an opportunity to learn to do interviews, to facilitate focus groups. And part of it included building the survey and the semi-structured interview. And it was brilliant because as it went on, I could see our primary investigators' light bulbs going off all over the place. Oh, I hadn't thought of that. That's a really good idea. Oh my God, I wouldn't have known. And so her research has gone from being what they thought it was about to what the patients and the family have made it. And out of this will come some process papers, etc. And it's been really brilliant. When I was assisting with the decoding from the data of the interviews, the woman I was working with, literally as we were talking about our results and our themes. And she literally looked at me and said, I'm so glad we had a chance to do this. This has changed my perspective on data analysis significantly. So for her, it was a really change in perspective as to how beneficial it was to have patients involved. She was beginning to see what gets missed, when it's only the researchers doing the analysis and breaking things down. And that was a real aha moment for her. And it was really delightful to me to see that we really could work as a team and really enhance the quality of the analysis that we were working on. And that same group has built this really strong dynamic because it is a level playing field. It's no longer us and them, it's we. And I think that is so significant. Out of this study, there's going to be numerous papers, including processes. How did we involve the patients? What was it like? What was their experience? What was the researchers' experience like, which is equally important. And I think that is an aspect that's missed when we look at patient and family engagement, is that we don't talk to our researchers and say, what's happening for you? What's going on in your world? What do you need to work better in this world? It tends to be a bit one-sided yet, and I'm hoping that we're going to open that door a little bit more. So most of our barriers are experience, education by far, and the networking among researchers and patient and family engagement on a small note. So that's sort of where I look at the barriers at the moment. So of course that takes us to our next, the second part of that question, which is how do we change them? I think one of the things that we can seriously consider is looking at doing a course. Let's get our researchers together and educate them on what the patient experience is like and how we can enhance their research and how we can be more integrated into what they're doing. And I think this, like I say, the papers coming out of this current study will bring some of that information with that. I also think that and this comes, I'm actually a kidney patient, and I sit on the research arm of the Kidney Foundation of Canada. And working with new investigators has been the most brilliant experience that we've had. And this really has been an opportunity. We write a combined paper that we work with them on their lay summaries, and we get a chance to talk to them one-to-one and find out where they're at and how they're doing with it. And I do think that gives them more confidence. It also gives us more confidence as well that people are starting to ask more questions. I think that we also might consider looking at doing potentially some education for patient and family as well. We don't have to be researchers. I do think if we understood the process better, that it might make it easier to include us, because we're not left in the dark going, okay, well, I know they did this was my first research, but they're doing something different with this one and it doesn't make sense to me. And many of us don't have the confidence to speak in a meeting and say, well, could you explain how you came to that? Because often, although we were a part of the meeting, that's a knowledge base that goes beyond what the meeting's about. So and there are some, at least in the Council of CKD is the one of the arms of educational opportunities for patient and family. And I think that that's been very helpful for those that have been able to take the courses. So looking at education for the researchers, education for the patient and family advisors, and really building not only a resource for the researchers so that they know where they can go to ask questions. Because I think that's a lot of it, because even though there's a lot of research out there, it's still very broad and spread over many different areas. So there isn't someone they can go to say, well, I don't know if I need a patient in this research, or I have a question for you. How do I avoid the tokenism or that type of thing? I think that would be huge. And then actually potentially, maybe now we've got PACER for the patient family advisors, which is about qualitative research. I strongly think that if we were providing something for researchers, that it would make a big difference for them as well, so that we're all starting on the same playing field and that we're not coming in from different angles and hoping that we'll work together, but making it way more difficult than it needs to be. So that's my take on it.
Yeah, that's fantastic. Before we ask another question, can you tell me what is PACER?
Oh, sorry. It's a patient and community engagement research. It's out of the University of Calgary. It is a patient-based program, patient family, and I've met many researchers that have been there as well. And it's about understanding the qualitative method of research. So the whole process of building interviews, facilitating focus groups, data analysis, and then of course bringing the paper together afterwards. It's a very demanding program. I graduated 2019, and it's certainly grown and changed. It's an evolving course as well. And I think that many of us actually, the passion that comes from it has been very valuable. So that's what PACER is.
Thank you. And I'll put something in the chat room if people want to find out more about PACER, but I just sort of thought we're always very sensitive to the acronyms that we use in healthcare, and then we're doing an acronym in this presentation.
Oh, we're doing it too.
Yeah, we're doing it too. So I thought, oh, we better explain what that is. So thank you, Nancy. And that, I mean, you've touched on some very interesting concepts, and I mean, I'm sure we're going to dive into a little bit more, but before we move on to the next question, Heather and Karen, I'm coming to you. Heather, do you have anything to add to that, especially specifically for your population that you're speaking for?
Yeah, so my
just tell people who you are. Who you're talking for.
My background is in youth mental health, so kind of anything encompassing that. I also have lived experience with chronic pain and just complex care in general. So what Nancy was talking about in terms of the barriers to research, especially being education, it reminds me of something my boss told me, actually. I'm currently working for an integrated youth service hub here in Edmonton, though technically it's online, so it's all of Alberta. And part of my job is doing a research component in conjunction with CAMH. One of the things that my boss mentioned to me, and one of the reasons that I got hired, is they're of the opinion that research should almost be like a trade or like an extra kind of certification outside of the academic cycle. They're very focused on like bringing in as many patient voices and focusing on that diversity within the workplace and the research and all that kind of stuff that we do. And they were saying, you know, PACER in training patients to be researchers is like one of the only ways that patients can have that academic kind of background in order to, you know, quasi justify their positions and their experiences in research. And, you know, it gives them that kind of, again, I'm using quotations here, but like validity to be in these professional spaces as researchers. So that's something that, I mean, it's helped me feel more confident knowing that, you know, there are people out there that are looking for that kind of experience. And I think it just speaks to the larger challenge of research, where it's, you know, stuck in an academic kind of bubble unless you have an exorbitant amount of funding from somewhere else. And if you do, like, the patient experience kind of just gets lost in those things, because you don't see a lot of patients in academia because it's so inaccessible, or you don't see patients in, you know, strictly funded studies because where are they getting the money from to hire these patients, you know? So that's something that like always sticks with me, is like making sure in any situation that research is as accessible outside of academia. And I challenge researchers to be able to train the people that they bring in. If they are bringing patients in, give them the training, give them the education. It just makes them a better asset for your project.
Thank you, Heather. Karen, did you have anything you wanted to add? Please go ahead.
I'm going to bring in something that Nancy said. It's about the complexities of having a patient partner involved in your project. We come with different we're ill. We have illnesses, like I have chronic pain and mental health issues, and I can't sit for long periods of time in meetings. So to be able to wander up and down and move around, and so there's other things like how do patients get to the meetings? Is there a mobility issue? Is there a financial issue? These are the kind of things that researchers come up against when trying to include a patient partner involved in their project. So there's accommodations that need to be made. And for the most part, patient partners are really good at finding solutions. So they shouldn't become barriers, but oftentimes they are. And for me personally, one of the biggest barriers is compensation. Because I'm on disability, I can't be paid because everything that I'm paid has to go back to the disability companies. So I have to ask for gift in kind or I don't get paid. And so that's become a barrier for me because some projects I can't take on because of the payment issues. So that's just a few things to think about when you're trying to bring a patient partner on board.
I just want to say to that, it's going to be a really big statement that I'm going to kind of gloss over really quickly. Challenge your idea of what accessibility and accommodations look like. It doesn't always mean for someone who's severely disabled. It can honestly just be something like, hey, I prefer if it's a little bit quieter in the office, or hey, can you maybe not wear that perfume because it gives me headaches? Challenge that constantly, because then those tougher conversations are a lot easier to have later on.
Thank you. Thank you for that. That's great. That was the first question. We're going to move. Yeah, Mo just sent me a note. Keep everybody, she said, just a friendly reminder. And I'm like, I'm moving on. So we're really good here. So thank you for that and for your comments. Again, the questions are broad enough to sort of get some of these comments and hopefully they, again, resonate with most. So Karen, you're the second question. And so, what does knowledge translation mean to you? And how do you think patients could be more involved?
Well, when you first approached me about this, I had no idea what knowledge translation really meant or what includes. And talking to this group over the few meetings we had, it's talking to people, talking to one another about things in education. And so having thought about that, I was thinking, how is a patient involved in knowledge translation? Well, I thought of a few things. The one thing the system is very good at is using system speak. And it's the biggest thing I have when working as a patient partner, to be, I don't want to say judgmental, but critical of the system speak when you're trying to develop something for a patient. So that's something that really needs to be looked at. And the other thing that I've been thinking a lot about is we have great papers that are out there, wonderful papers that go to research organizations and magazines and stuff, but the patients are involved and there's nothing in it for them. So they don't understand the paper. They don't get to see who it goes to. They don't get to see any of the benefits or the fallout from any of that research. So having thought about that, I thought, why can't patient partners write their own paper based on that research and have it geared towards patients in general? Because it is about us ultimately. You are researching on behalf of patients or to make a better product or something. So why not bring it full circle and have your patient partners that are involved in your project write a paper specifically for other patient partners? And that is something that I am really starting to be advocate about, because I think it is about us. And there's a saying, for patients by patients, right? So if we're putting that work into a project and it's benefiting the research and it's benefiting the system, why shouldn't it benefit the patient more broadly? So that's my answer to that question.
Okay, that's really interesting, Karen. So can I ask you, so if you were to put let's call it a patient publication. So you're going to put this patient publication together, where should it go or what should we do with that?
That's a good question. I'm sure there's publications out there that will take that on. I don't know personally, but we could get it into community groups. We could get it onto, the Alberta Health websites, SCN websites. There's a lot of patient partner groups that are wanting to read stuff like that are starting to get more involved in what's out there. So just off the top of my head, those would be where I would sort of, and word of mouth, share it with other patient advisors, share it with everybody you know, because we're a group. We may not all know each other, but we do talk to each other, and we're great recruitment tools. So Nancy's laughing at me because we do share projects with each other, and it's not you're not tapping into a very valuable resource if you're not using that as part of your recruitment strategy.
Okay. And thanks, Mo, for the SCN. I was just going to say, Karen, what does SCN mean?
I know. I'm sorry.
Right?
Yeah.
There's no need for the sorry. I think it just sort of speaks to it's a forgiveness. So when the researchers and the we're doing it, now you can understand why we it's really easy to do. That's why they have acronyms, because you don't have to say strategic clinical network, SCN, or patient and family and community engagement researcher, PACER, right? It's so much easier to use the acronyms. So it's fine. It's we're just going to try and keep on top of those. Okay. So, but I also curious, no, and I understand. So it would be interesting to perhaps explore other areas where the research could be shared. And I mean, I think that's a really interesting and maybe a great takeaway, especially for this particular group. Because again, KT, knowledge translation, I almost used an acronym myself, is in my most biased and humblest opinion, the most important part of the research process. And, it's sort of at the end. And so, it's how it happens and where it happens. It's primarily in academic publications. And so there hasn't been this exploration or consideration of things beyond that. But it also speaks to some of the barriers that we mentioned earlier that still exist, because we don't have these relationships, or we don't have this, resource that's available to all of us to be able to sort of entertain some of these, these considerations or concepts. But going back to this, you speak to each other, and that you're all connected and you're very good at recruiting. So it led me to this thinking about, do you think that patient partners are underutilized with respect to recruiting or getting the word out with knowledge dissemination? I'm going to use 100%, the academic.
100%.
Tell me more.
Absolutely.
Tell me more, Karen. So go ahead, sorry, Heather. Yeah, go ahead.
So I see it in my own job now, kind of working. The study itself is national, but the recruitment strategies that they have are so like limited and kind of just absolute baseline to say, hey, we tried our hand at recruitment and it didn't work. That's why our numbers are low. It's things like, simply putting up a poster at the site being like, hey, you should come and do our research, or, contacting these other, specialists and caregivers to be like, hey, you should maybe talk to your patients about this. I'm sitting here as someone who's on, 4 different advisory councils, and I see the offshoots coming off from that. And I'm just sitting here saying, no, there's so much more that you can do, and so many more established areas for recruitment that you're just like, it's almost like a naivety where they're just like not even trying to look into this, and they're just completely unaware that these exist. You mentioned advisory councils, or you mentioned these, student-led or patient-led kind of projects going on, especially in the youth mental health sphere, where there's constantly something going on. And I've seen so many researchers just look at me with kind of blank eyes or hollow eyes saying, sorry, what's that? What are you talking about? What do you mean there's 3 different advisory councils on this topic already? What do you mean that there's, this project here and this project here led by this person here that I know very well, that I've, talked to so many times? What are you talking about? And I sit here being like, yeah, like I'm part of these groups. These are groups that I already know about, and groups that I'm like well established within, and I'm only one person. I can only imagine of all of the things that all of these other people are doing. And it's so shocking to me that researchers that, this sounds cynical, but, experts in their field, and they don't know about these things that patients are already creating themselves. It baffles me.
Fair enough. Yeah, thank you for that.
If I can just add another thing, the thing that I do if I'm involved in a research project and recruitment comes up, I will say to them, do you mind if I help with the recruitment? And I will email the information to the groups of people that I know and say, here's just an opportunity. And I leave it at that. And most of the time I get 1 or 2 people involved in a project. So, ask your patient partners to be part of that. And you'll be surprised at some of the results.
Yeah, no, thank you for that. I am looking at the time. We have to move on to the third question, which we talked about that we could probably do an entire half-day fireside conversation about these really interesting areas that we're talking about. But Heather, going back to you, we were joking together when we were talking about this question about how weird the word ally, right? We were breaking it down. I know, and I said I might as well just get it out of the way. I don't know how many times I've said allyship. That's what the word is allyship. But the third question, it's not. The third question really is about this allyship, right? So, which is really an inclusive word. But what does this mean to you, and how can health research be a better ally to you, Heather?
It's something that, just the concept of allyship is something that I've experienced a lot and looked into a lot. I'm a young person on the internet, like this kind of feminist and social theory just kind of pops up constantly. As a queer person, it's something that pops up constantly. How can, straight communities be allies to us? How can cis communities, how can cis people be an ally to us? And ultimately, allyship is just partnership. Allyship is having that relationship with someone and recognizing that 2 people can come together and solve a problem, each with their own strengths and experiences. In health research and in a health context, think of it in terms of doctor and patient relations. The doctor comes in with their experience as a clinician, as having that knowledge, having that treatment base. But the patient also comes to that appointment too with their own experience and their own expertise in how their bodies exist, how their conditions exist within them. And I think coming to that together with, the doctor recognizing, hey, I don't know what this looks like on you. And the patient saying, I don't know what this looks like in the scientific medical context, and coming together and approaching the issue together is really, to me, the best way to do that. In health research, we've already touched on it again with Nancy and Karen, but for me, it's going to be removing that access and removing those barriers, to things like having advanced degrees or, specific software knowledge. I've heard of people getting turned away for research positions, being knowledgeable, being experienced, but not knowing this one particular statistical software package. And immediately that's what's, the straw that broke the camel's back in terms of hiring them. And for patients and for people with disabilities and for disabled people, like, more and more barriers to access just means less and less people accessing those positions. I've been privileged enough to be able to kind of mask or pass as an academic. And I know that's helped me get to the positions that I'm in today, but I know that for most mentally ill folk and most mentally ill youth, that's not the case at all. And having those voices and having that perspective in research or in policymaking for youth in particular is so, so, so important. But until researchers and policymakers kind of take a step back and realize that they can't have those expectations for people disabled or not, it's not really going to happen, right? Having more voices in projects just creates better information and creates better policy and creates better research.
Yeah, but I mean, and I mean, ladies, we are coming to the unfortunate, not the end, but we need to open it up to question and answers. But Heather, that's a great way to sort of carve off the next part of this conversation. Mo, I'm going to turn it back over to you. I know you've been and Megan have been monitoring the chat. I'm going to start looking at it now too. But please, if there's some questions, we're going to close off this fantastic conversation. For some questions from the audience. Thank you, ladies and gentlemen and others and folks. That's my inclusive.
Thank you. Thank you to the panel and thank you, Tamara. And so, yeah, there's been a lot of interesting and diverse discussion here in the chat. I've been following, and thanks everyone for contributing both comments and responses to some of the comments. But I know Megan will take you off of mute, or if you want to put a question or comment in the chat, please do so for both the panel and Tamara. I'll give a moment or two to see. So we do have here for Heather, have you noticed any positions where you have already gotten rid of those academic and technological requirements? Thank you, Paula, for that question.
So, kind of. So I did the investigators program, which is a program run by CBRC. I took it through the Edmonton Men's Health Collective Centers Clinic. They're recently changing their name to the Queer Trans Health Center in Edmonton here. It's basically PACER, a qualitative research training program, but with a queer perspective instead of just strictly a patient perspective. With that context, I found that the CBRC, I'm not entirely know what that acronym stands for. They're doing their job postings are a lot more kind of accessible. So you know they have started lessening a little bit of that academic and technological requirement. That's kind of the best example where it's, you know, there is no formal education required, but hey, if you have experience, that's going to be a bonus. Or we want to make sure that we're not turning away anyone with disabilities. So if you do need accommodations in order to submit your application, please contact us and we can figure this out. So that's kind of the best that I've seen. Beyond that, no, they still require academic requirements. There's still, you know, a laundry list of things that you have to get done. My position with CAMH had like minimum of a master's degree and 5 years of experience in, you know, all this kind of stuff. Yeah, I'll link it at the end. And because my boss kind of made a point of removing those barriers, they actually said, you know, you have PACER, you have experience with qualitative research already. You don't need a master's degree. I'm wiping that as a requirement. You don't need this kind of experience. You're a patient already. You don't need this requirement. So I think structurally, no, but I think there are still people that are removing those requirements on their own.
Thank you, Heather, and thank you for the question, Paula, and thanks, Heather, to follow up with some links to the organizations. There's a question here from Kate. Do you think these academic requirements are a barrier to engaging beyond the usual suspects? Excellent question. I'll put that out there for anyone on the panel or Tamara.
I would definitely say yes to that. I think that it creates this lovely little group that you have to have all these check boxes before you can join them. And we know from our PACER research and we know from patient engagement that that's not necessarily a requirement to make things happen. And I do think that we lose some extremely valuable insight and input and direction by creating these sky-high requirements for a position.
I think all we want to do is just be an expert at the table, because we are experts in our own lived experience, and to be acknowledged like that is basically what I personally expect. I'm not willing to go and get a master's degree, but I'm willing to learn programs and stuff like that. But just to be accepted as another expert at the table.
Mhm. Great, great. And as a patient-oriented researcher, putting that hat on and listening to your answers, it's so true that, like, as they say, the usual suspects, right? These criteria, the expectations, outside of even skills and knowledge, but time and time and how we schedule our setup, or like meetings, and not taking into consideration a lot of other things, and base it on how we've always done things and continue to do those practices. um and so Kate says she absolutely agrees that lived experience is expertise. And maybe you could comment on this too, is expertise but also evidence. Like, how would you see that? Because I feel that my years of learning, co-learning with my patient partners, and also wearing a hat as a patient, as a caregiver, that the idea around, that evidence, that experiential evidence. Can maybe comment on that? Anybody want to comment on that? Or if you've seen this is changing or not?
It's funny you should say that, because when evidence-based practice first came out many years ago, I remember saying to my boss, well, where am I going to find this evidence? There is no research to support what I do. And she said to me, your evidence is, and it wasn't the choice of words, but essentially was my lived experience, that my years as a therapist counted as evidence because I had learned from that. And I think that applies to lived experience, period, that is our evidence as to what works and what doesn't. And I do think that puts things on a more level playing field when we look at it like that.
Thanks, Nancy.
I have a comment myself. I was gonna kind of keeping stuff. I've always explained it to people that if we have to put people in boxes, because this seems to be what we do best, is we putting people in boxes and all those things that we do. We take the burden of the methodological expert. So when we're doing a research study, a scientific study, so that's the burden on us, is to make sure that methodology is rigorous and that that what we learned in school is upheld. Any patient or family member that I've ever worked with, I'm like, that's not why you're here. I want you to bring your lived experience to this. And so, and then hopefully we're having a dialogue with each other about, like, if Tamara, I don't know why we're doing, okay, we do this, like this member checking or something that we're doing in qualitative research. I know I'm using academic terms. So like, why do we do that? It increases the rigor. So the rigor is important, that, we're unbiasing sort of some of the results, but it's explaining that and having that dialogue. And so it's again, I don't want to hear what this means this way. I want to hear what you have to say in the context of these findings and what it means to you with your lived experience hat on. And I don't know if that's helpful but that's how I've always looked at it.
This is a little bit off topic, but I just want to mention, in the context of being a patient, like a patient researcher and a patient advocate, and coming into these jobs and these positions saying, I have X lived experience as a patient. I don't want to, like, with this, I want to instill confidence in people, and I want to have people feel confident saying, yes, I am a patient. Yes, I have my own experience. That said, I'm not going to lie. Something that I've always struggled with is, like, how do I know that I'm safe in these situations? And how do I know that I can say, I'm a patient and I have experience as a patient without it hurting me detrimentally? I haven't figured that out yet. And I'm really sorry I don't have an answer. But I think just knowing that feeling's okay is something that I just want to mention as well. And knowing that, these are hard conversations to have. And yes, you should feel confident that you have this expertise, but explaining the expertise can be really, really challenging and hard.
Thank you. Thank you, Heather. I'm just looking at the time, but I do want to highlight a few things. One last question before we go is about, just connected again, how do you value or put reimbursement or wages for this experience that you bring to the table? What does that, a quick overview comment on that and what you've had for that compensation for that experience and your time, etc.?
This is something that's difficult for me because I have to be very careful what I accept because of the payment issue. I can't receive a check. I can't receive anything like that. So most of the time, the researchers are really good at finding alternate ways like gift cards but again, they only have a limit too in terms of how much they allocate for patient partners, right? So it's definitely, I feel we're underpaid for sure. But for me, and I'm just talking about me personally, it isn't about the money for me, and it never has been. It's been about advancing my lived experience into a project to make that a richer outcome. And to me, that's the payment. If I see that happening, then I'm willing to put in X amount of hours to get that done. But compensation is something that probably needs to be talked about, and at some point as the patient partners grow into more research projects.
Thank you, Karen. I'm just going to bring to close, but you bring up a few good points, Karen, around the idea, what drives people, or what value do patient partners, what do they value in coming to a research project or a program of research, however you want. And you brought up a good examples of what brings certain individuals to this work. The second thing before we close off here is the idea of, like, for myself, co-learning, and that whole co-solving the problem. One of you guys mentioned that is excellent. That's the whole thing. It's about this collaboration, the idea around the power dynamics that still exist for whatever reasons in terms of role that you play, or how it's envisioned by the members of the team. And finally, that safe space, that, creating a safe space that is so important. And so thanks for sharing your experiences. Thanks everybody in the chat. The comments have been amazing. The questions have been amazing. And I know there's some things that are still, I see Tamara's put some information in there. And so finally, I want to just say thank you to our panel and to Tamara, and thank you, Megan, for supporting from KT Canada for our seminar series, and remind everyone to complete the online evaluation in terms of the we like to know what to bring forward to KT series, the seminar series, and diversity of topics, and how please complete that evaluation. And this is our last webinar for until the fall. So stay tuned for September 8th, where we're going to have Dr. Lori Rosny from Nova Scotia. And when she's going to be talking about her work in mobilizing knowledge for digital equity. So please pass the word along. I know Megan will be sending out reminders and information about that session. And again, thank you, Tamara. Thank you all for participating. And thank you to the attendees today for spending this hour with us, and for a very fruitful conversation.
Thank you so much, everyone.
Bye-bye, everybody.
Take care, everyone.
Have a good day.
Bye.